Throughout this course, the connection between hormones and neurobiology has been our foundation. As we have come to learn, much to our dismay, there are many spaces within which we need to fill in order to gain a complete picture of what really guides our brain function. As we've read about week after week, the ignorance about women's health, whether conscious or not, has led to not just direct detriments on women's health outcomes, but also precipitates into the quality of health for everyone. In this presentation, we're going to take that same lens, but apply it to another widely marginalized group and discuss the biology and societal experience of those who are intersex. Now, there are many ways someone may identify as intersex. These ways span from how someone's genitalia may appear to different chromosome types, XXY individuals, for example. It is estimated that people who identify as intersex make up 1.17% of the population, which is on par with those who are born with red hair, or even the percentage of twin births on a worldwide scale. This serves to illustrate that this is not some rare anomaly and gives even more weight to our research efforts. We hope this presentation serves to help change the profound societal stigma surrounding intersexuality, and that you find it as interesting as we did as we explore.
Caster Semenya is a South African runner who won gold in her Olympic debut. However, as an intersex individual, her past has been marked by struggle. Her sexual identity was questioned due to her muscular appearance and beard. Physicians forced her to undergo a sexual verification test and found that she did not have ovaries or uterus, and she had over 3 times the testosterone level of the average woman. The IAAF labeled Caster and other intersex as having a disorder of sexual development and mandated testosterone suppression or surgical removal of their testes. Since then, Caster has been appealing to the court for unfair treatment. She is banned to attend future events including the Tokyo Olympics. Caster's story generates many questions. Why can't a woman compete with other women? Does the IAAF believe that a woman with XX chromosomes is somehow more female than a woman with XY chromosomes? In fact, World Athletics acknowledges that these regulations are discriminatory, but still insists that they are necessary for fair competition. However, how can discrimination be fair? Caster says she would fight until we can all run free the way we were born.
Well, there are so many ways that someone can be intersex. Let's dive into the biological mechanisms behind androgen insensitivity syndrome, or AIS, which is what Caster Semenya experienced. Individuals with AIS have XY chromosomes. A mutation in the X-linked gene encoding androgen receptors disrupts their ability to bind androgens. Genotypically, AIS individuals are considered male. However, the fact that someone has XY chromosomes does not necessitate that they identify as male. We want to make clear the distinction between chromosomes and gender identity. Androgen-insensitive individuals have unique developmental experiences. An XY embryo with complete androgen insensitivity will develop testes upon activation of the Y chromosome sex-determining region. The testes secrete Mullerian-inhibiting substance, preventing formation of the cervix, uterus, and fallopian tubes. However, because the embryo is insensitive to androgens, no further development of biologically male sex characteristics occurs. The external genitalia appear biologically female, the vaginal canal is shorter than average, and the internal gonads are testes. This developmental pathway mirrors the unique experience of intersex individuals throughout life. Intersexuality is not a syndrome or a disorder. Rather, basic biology illustrates that intersexuality is just an iteration of the human condition.
Just like how the intersex embryonic development is unique, the experiences of intersex individuals through puberty and adulthood are unique as well. So what are some of the experiences that a CAS individual would go through? Well, amenorrhea or menstrual failure is the most clinically observed sign of those with androgen insensitivity. And of course, this is observed at the start of puberty since that is when menstruation begins in typically developing individuals. Testes being found as a result of a hernia is also indicative of CAIS. Additionally, the testes are usually surgically removed due to risk of cancer, and lifelong estrogen replacement therapy is needed thereafter. Puberty is typically marked by the growth of pubic and axillary hair, but this is not the case in intersex people. But breasts do develop, and these individuals usually grow to above average female height, but they are still shorter than the average male. Additionally, all forms of androgen sensitivity are associated with infertility. As we have learned in this class, increases in sex steroid hormones occur at puberty and can provide additional organizational and activating signal to drive permanent changes in brain function. And in adulthood, gonadal steroid hormones can activate or inhibit brain regions to modulate function. In an individual who is not receptive to certain hormones, such as androgens, these mechanisms are altered. And while androgens can act by binding to and activating receptors, they can also metabolize into estrogenic molecules to impact estrogen signaling in the brain and periphery. But there is more research to be done in regard to the neuroendocrine function of androgens and how CAIS may impact brain function. Because sex steroid hormones are a key factor in various behavioral sex differences, they may serve as a basis for sex differences in human anxiety. Increasing evidence suggests that activation of androgen receptors mediates masculinization of the nervous system and behavior. Through studying androgen-sensitive rats, researchers have found that testosterone plays a regulatory role in the HPA axis through androgen receptor-mediated anxiolytic effects. Thus, a CAIS rodent has a dysregulated HPA axis and higher corticosteroid levels. This biological phenomenon may provide insight into the higher levels of anxiety experienced by intersex individuals. Despite increasing acknowledgement of hormonal contributions to mood and anxiety disorders, the underlying mechanisms by which gonadal hormones influence psychopathology-related behaviors have room for further research. In the words of Hampson 2014, given that anxiety is widely reported as a precipitating factor in depression, studying the role of androgen receptor in anxiety may provide insight into the pathogenesis of major depressive disorder.
Intersex individuals face a lot of obstacles to receiving proper health care. This in part stems from how, in the International Classification of Disease by the World Health Organization, intersex characteristics are classified pathologically and present codes that are associated with unnecessary medical procedures that violate basic human rights. There has been a push by researchers and intersex advocates for the WHO to modify their report and use neural terminology rather than pathological, but these changes have still not been made. About 80% of intersex people have changed their care because their providers, one, are not educated on how to appropriately care for intersex patients, two, use stigmatizing or outdated terminology when addressing them, three, they present and treat intersex people's bodies as a medical curiosity, such as performing unnecessary genital examinations. In 2016, the NIH formally designated the intersex community as a health disparity population.
Historically and to this day, treatment for intersex individuals or those with ambiguous or unique genitalia have been assigned a gender and forced to undergo reconstructive surgery to align their genitalia with that assigned gender at a young age. Typically, those with complete androgen sensitivity are raised as girls. Following the gender assignment, males are given high levels of testosterone in order to increase male features, while females go through gonadectomy to decrease viralization, the development of male characteristics, and genitaloplasty in order to reconstruct the look of the genitalia. The problem with this is that the gender assignment and following surgeries are conducted within the first few years of life in a time period during which the individual is not able to consciously consent to that choice, and the individual grows up without any knowledge of their intersexuality. Even though much of the treatment involved for CIS individuals revolves around sex reassignment and the adjustment of that sex, according to a study in 2020 examining intersex individuals, over 25% of participants still ended up viewing themselves as non-binary, leading us to question the importance and usefulness of this treatment. They also found that there were significantly higher instances of health issues mentally and physically compared to the general population. Over 60% of the individuals reported having depression or an anxiety disorder. Meanwhile, a quarter of individuals reported having health conditions such as fibromyalgia or osteoporosis, diseases that can be caused by an irregularity of hormones. The grossly large proportion of individuals suffering from diseases such as osteoporosis highlights the lack of understanding of the needs that intersex individuals require throughout their life. As it stands, there's a lack of research done to help the intersex with their increased risk of these diseases, even with gonadectomy and hormone therapy. For example, there's unclear guidelines for doctors on how to screen and monitor for osteoporosis for intersex individuals, as there are many factors that can complicate screening, such as whether to use their natal or assigned sex, when they started to use hormones, and how long they have been using hormones for.
To date, no research study has sought to simply understand the neurobiology of intersex individuals, let alone use that knowledge to propose clinical practices to improve their health outcomes. The vast majority of publications focusing on intersexuality have viewed it as a medical disorder that needs to be treated, as opposed to a valid biological and social identity that deserves to be explored.
As you can imagine, as we have went through this presentation, one of the most concerning realizations we had was the lack of research and understanding of what it means to be intersex. Therefore, our group had many questions that still have yet to be addressed adequately. These range from psychological questions such as how stigmas towards individuals who are intersex affect stress levels, to more physiological ones such as does the activation of neuroendocrine systems due to the stress, say the HPA axis, lead to negative health outcomes? And there are many, many more questions still left on the table. We hope these questions spark future research that will lead to greater understanding and acceptance of intersexuality so that all people may, as Castor put it, run free the way we were born.